Good morning. I'm delighted to be here. I'm so glad to see, I was just saying to my colleague Dorothy that I speak often to quality groups and physician groups, and I just am so glad to see people who aren't 55 and older only in the audience. It's just not, well, I am a 55 and older person, and I'm just glad to speak to people who aren't my peers or older. It's just really, because solving the problems that we are here to talk about solving today is going to take more than just those of us who are 55 and older. It's going to take everybody. I'm an advocate of talking about conflicts of interest and potential sources of bias. And so I'm going to start by telling you mine. I speak as a person who's been diagnosed 4 times with cancer, and I live every day with the sequelae of that many diagnoses and that much treatment. I'm a really frequent user of healthcare, and I draw on my experiences to inform my own work. I also speak as the president of the Center for Advancing Health, which is an independent, nonpartisan nonprofit organization in Washington, D.C. I founded CFAH in 1992, and since that time, our aim has been to shine a light on the role of people's behavior in their health and their health care. In particular, CFAH is interested in and works on patient engagement. What does it take for us to find and make good use of the health care available to us? CFAH listens to people talk about their experiences with healthcare, and then pulls it together and presents it to decision makers and clinicians and policymakers so that they can help us take care of ourselves and our families better. CFAH is supported by individuals and foundations only. We receive no industry support and no government support. So let's talk about one of your potential sources of bias. How many of you have been hospitalized for more than 3 days in the past year? How many of you or a family member have received a life-threatening diagnosis in the past year? How many of you live with a chronic condition that you have to attend to like 2 or 3 times a day? And how many of you have only had really kind of mild encounters with healthcare, antibiotics for an infection or looking at a sprain or something in the past year? Yes, 55 and under. You can tell, huh? But many of us here have been, for example, the parent of a sick baby or the child of an ailing parent. Obviously, some of us have experienced chronic or acute illness ourselves. And so many of us personally know that healthcare is this kind of delicate balance between the cognitive and the emotional, the objective with the subjective, the knowledge with experience, and individuals with populations, right? All of those things go into the mix. Most of us know that when we or someone we love is ill, our concerns about health and healthcare really weigh heavily. And all of us who've been sick in the past year certainly know that getting good care requires a lot of kind of unexpected hard work. And a lot of that work is undertaken when we may be feeling quite pokey or horrible. Anything that can be done to relieve the burden of that hard work and the unfamiliarity and the uncertainty that we feel when we're sick and seeking care is so very welcome. But we also know that most of us, for the vast majority of time, our concerns about health are crowded out by, our lives, our kids or our parents or our pets or our damn super or the subway schedule on the weekends or, you know, our deep abiding interest in goofing off, you know, they just crowd out health and, you know, whether we should be on a diet or exercise or, it's just like, we got other stuff to think about. Life intrudes. For the 3/4 of adults who are online, figuring out how to use the health tools and apps and programs and websites that are available is really an ever-changing puzzle that looks different as those tools change, as we become more familiar with kind of and accustomed to looking for health things online, and as we drift in and out of health. So what I want to talk about today is how social media might help make this puzzle a little less puzzling for us. I'm going to reflect just very briefly on my experience with social media over the past year as I've been treated for stomach cancer. Then I'm going to tell you about what we've learned from interviews and focus groups and surveys about what people want and need in order to get good care and make the most of it. And then I'm going to identify some points where I think social media of various sorts might be able to really have an impact and help us. So, my experience. When I was diagnosed with stomach cancer in the fall of 2010, I had great expectations that advances in HIT generally and social media specifically were going to really dramatically change my experience of treatment as opposed to the 3 other experiences I've had with cancer treatment. As a patient advocate and as someone who directs a nonprofit organization with big social media ambitions, this was really going to be the bright spot in the middle of what was otherwise a pretty grim time in my life. And, you know, I really was dazzled by how easy it was to find pretty basic information about my disease and possible treatments. You know, the more specialized information that I needed was behind the paywalls of academic journals. And none of the surgeons or oncologists I used were listed on any of the doc rating sites, nor were any of them willing to use email with me. In choosing my doctors, I de facto chose my hospitals, so I didn't need to look at hospital ratings, or it would have been frightening to look at hospital ratings, I think, in hindsight. And I'm really grateful for the online access that I had to friends and colleagues all over the world who were just really helpful to me. And, you know, when you first get the news of a cancer diagnosis, it's just really difficult. And it was wonderful to have access to so many people who gave me so much support. But I have to say, you know, once I started treatment, I was really weak and I was really sick. And feeling bad snuffed out all of my curiosity about stomach cancer in any form. It dampened all my interest in looking at alternative treatments and looking at new ways to handle symptoms or seeking innovative approaches to like aid my recovery. And only occasionally, very occasionally, could I summon enough energy to talk in person or by phone to even very close family members. Email was just overwhelming, and the idea of talking to people I didn't know or trying to sort through or find people like me who were experiencing the same thing was just unthinkable to me. So as I've recovered, I've sought more information online. When a symptom flares up, or I have a question about a side effect, or when I need a prescription refill, or when a doctor's recommendation doesn't seem to be working for me, you know, I look for very specific answers to my very specific questions online. My dominant feeling, though, is I want to spend as little time as I possibly can getting these answers. I am cautious, but I am not curious. As long as I'm doing okay, I do not want to hear from my doctors or my clinics or my hospitals, and I don't want to think about them unless there's a specific reason that's related to me feeling better. I don't count my ability to donate to the hospital as among the reasons that I want to hear from them. Healthcare is necessary for me sometimes, and I'm grateful for what it's done for me, but I figure that my time and my doctor's time and my hospital's time can be much better spent on other things as long as I'm doing okay. Now, my health history is odd and hopefully not shared by many. And my sophistication and interest in social media is not typical of the general population. But I have heard again and again from the public that my attitude of I only want to know what I need to know when I need to know it about healthcare is representative and of many people in this country. So let me talk just a little bit about the experiences of others. It's this attitude of I only want to know what I need to know when I need to know it, that those of you who are interested in reaching large numbers of people through social media need to take into account when you build your efforts if social media is ever to really become truly useful to us, which from the patient's perspective is the goal, right? Don't be seduced into believing that because more people are online or more people have access to smartphones or more people are using health in searches, that this is by any stretch of the imagination a slam dunk for social media. The opportunities are there, but they're strategic and they're focused and they're going to require energy and resources to fully realize. So consider, will we use social media just because it's there? Well, the migration of health care services online often rests on the assumption that if we can explore and search and compare and communicate and purchase online, that we're going to do so. And on some topics and in some venues, that really has been the case. But an article last year by Cyrus Yamin and his colleagues that appeared in the Archives of Internal Medicine suggests that you pause for a moment. They studied a really large population with uniform access to a really excellent EHR that gave them their medication lists and laboratory results, and they could make appointments and they could communicate securely with their clinicians, right? This is kind of like the basic meaningful use, what we want to see in an EHR, right? And what did they find? They found that out of over 75,000 people, 43% used the EHR, and of those who went on, half went on once or less. I don't exactly get the or less, but this is not a pretty picture no matter how you paint it, right? It's easy to be lulled into believing that the lack of internet use has to do with the lack of access and that that's going to be solved with smartphones. This study suggests that access is only one piece of this puzzle, and that those of us who lack literacy, cognitive literacy skills, cognitive capacity, experience, enthusiasm, interest, and confidence may have trouble with this and just may not be adapting to this anytime soon. There are a lot of us out there who meet these criteria. So, we'll just age out of this any day now, right? 55 and older, we're gone. Not so fast. The age group who tends to need to be the most frequent users of healthcare is composed of those who are least likely to be online, of course. You know, we don't use computers, we don't use smartphones, we don't have broadband access, we lack search skills in general. The whole notion of acting like a savvy, informed consumer is just kind of beyond us, you know. It's unthinkable to challenge the authority of our doctors or our nurses. We won't complain directly to our hospital, and we don't even ask questions because we think it challenges our doctors' authorities, even if we don't know what we're supposed to do to take care of ourselves. Don't worry, you say, so these people are getting taken care of by their kids, and their kids do have access, and they have these skills, and they are ready to do all this work. Well, you know, I say be careful with that easy assumption. This is true for some, but it's not true for a lot of people. You know, we're alone, or, you know, in this highly mobile population, the kids' help takes place twice a year coming in from California, or, you know, by phone, and it's reported by older parents who are fiercely independent or moderately forgetful and who just don't want to bother the kids. So there's a real, you know, where we assume that, where there's an assumption that there's accuracy in reporting and that family units work accurately and competently together, I think we need to reconsider that as we have this large group of people who are still kicking and using a lot of health care and are really struggling to get good care when it's so chaotic and difficult to navigate. Okay, so these people are going to age out. Yeah, they're going to age out right along with those doctors who, you know, won't use email and insist on writing their chart notes with their cross pens. But, you know, they're going to be around. We're going to be around for 15 more years at least. I mean, this is a project. We're living longer. There are more ways for us to stay alive longer. We're the ones who are using the older of us are using more health care. We're more expensive, and we need the most help. And what's social media going to do for us? So yesterday, Ferris Timoney said, close that door. Thank you. Yesterday, Ferris Timoney said, we live and die by HCAHPS. How many people in here live and die by HCAHPS? Oh, there should be many of you. Do you know what HCAHPS is? How many people don't know what HCAHPS is? Ferris Timoney, stand up and tell them what HCAHPS is.
There are quality metrics that are used in actually care hospital to hospital. Now, the reason I focus on the 3/4 of the protection, how well your doctors explain things to you, how well your nurse explain things to you, how quickly do you care when you need that, what your parents say. Now, there are powerful metrics, but the metrics that many of us don't have methods in place to try to address.
Thank you. Thank you. This is an interactive presentation. So, as a person who has filled out many HCAHPS surveys, I vote that those of you who live and die by HCAHPS live by it. And here's why. Responsibility for big chunks of our care has been shifted on to us and our families. We have to juggle the diets. We have to take the pills. We have to take care of ourselves after we're discharged from the hospital. We have to we have to do all of this stuff, right? Without and without our informed participation in our care, the possibility of our getting better is compromised, right? If we don't do those things, the effect of healthcare will be muted, right? Now, hospital and physician payment is increasingly linked to our outcomes, right? Pay for performance, shared savings from ACOs, all of these things depend on us doing better as a result of our health care. But tell me, how likely is it, do you think, that we're going to make the heavy lift of engaging in our health care if our clinicians don't listen to us carefully and explain things so that we understand them? That our clinicians don't answer questions when we have them so that we know how to care for ourselves at home? How likely is it that we're going to really engage in our health care if we're dismissed by our clinicians and they treat us disrespectfully? How likely is it that we're going to really feel like, yes, we're going to join in with our care if the facility is dirty and it's littered with, old gloves and wrappers and stuff? You know, I think that this kind of mistreatment is going to spur some people to become engaged, but we're not going to be happy engaged. We're going to be angry and oppositional engaged. And the rest of us who aren't angry are going to just say, you know, healthcare sucks, and just go on being passive people. HCAHPS scores indicate to you, those of you who care about HCAHPS, whether we think it's important that we engage in our care, that it's possible for us to do so, and that it will make a difference, and that it's safe for us to do so. And good HCAHPS scores indicate that we believe that a hospital or a clinician or a practice is all of these things, that the care that is delivered is important, that it's possible that we can get better, and that it's safe. So good HCAHPS scores are necessary for us to engage in our care, but they're not sufficient. Our question today is, how can social media help those who need the most help to navigate this very chaotic healthcare system and who are online, even in the most rudimentary way? How can it help us understand our role in the success of our care as important and possible and safe? And then to support us in participating as well as we can in getting the best possible outcomes. So here are some observations about what's known about how we think about and use healthcare that should be useful to you as you develop social media strategies to help us to solve the real and often really difficult problems we face in finding good care and making good use of it. This is an important thing for you to remember. Only about 1/3 of us are actively engaged in our health care. A few years ago, CFAH developed the engagement behavior framework, which is a taxonomy of 43 behaviors that everybody has to do at some point in order to engage in their healthcare, in order to fully benefit from their healthcare. And then we reviewed 31 national healthcare surveys to assemble a kind of a rough epidemiology of how engaged the American public is in their care. Here are links to these two documents. So we found that for the vast majority of behaviors in the engagement behavior framework, only about 1/3 or less of the respondents said that they did it usually. And this finding corresponds, for those of you who are familiar with this work, this finding corresponds with Judy Hibbard's work on the patient activation measure, which asks people how confident they are in being able to make good use of health care. One thing that the interviews that we did in developing the engagement behavior framework clearly showed was that while people really get this engaged patient idea, I mean, they can really spout those socially desirable responses. Oh yes, I'm an engaged patient. I always ask questions, and I always, they really, when you ask them specifically, did you at your last visit ask a question? Nah. Most of us are pretty clueless about how to really make good use of our health care, right? I think this is because most of us are mostly not sick most of the time, you know, and we really don't track changes that have gone on in healthcare. So we don't know that, you know, there are so many different drugs and they're generic and we don't know that there's so many specialists. We don't know that they don't or do communicate with each other. We don't know how much administrative work we have to do in order to really benefit from our care so that all of our doctors know what one another are thinking. At every step in the healthcare process, and those of you who've had healthcare, have used healthcare in the past year, knows that every step you discover there's a new rule or a new procedure you didn't know about. How did that happen? And each practice you go to, each hospital you go to, has a whole different set that you have to learn. It's amazing. If I had free all the neurons that are taken up with the rules that I know about how different hospitals operate, I would be so much smarter, I gotta tell you. So one lesson I draw from the CFAH experience, listening to people talk about their healthcare, is that there's an opportunity to use the tools of social media to target those of us who have online, who are online, to really help us understand how to get good care. You know, in the process of doing the engagement behavior framework, we organize the kinds of information that people need in order to really get their care. Like what are the kind of the basic barriers that things that people don't know that they need to know in order to get good care, right? And you can find some of this information here. So it would be really great, for example, to have interactive maps of the hospital or large medical centers particularly. That would be so helpful. It would be really good to have information about, for example, how a clinical practice works. You know, who do I call about an insurance question or a prescription refill? What are the procedures for after-hours care? Kind of like knocking down the different ways that you triage yourself to the emergency room, to calling the advice nurse, right? How do I get an appointment? How do I get questions answered if something comes up situationally? It would be great for every kind of intrusive test that my doctor orders that he or she gives me a YouTube link so that I can prepare for it and I know what to expect. And until the financial patchwork of payment and insurance settles down, in my dreams someday, any help that we could get to organize and understand what our responsibilities are for payment would be just so incredibly helpful. I mean, those of you who have used healthcare in the past year really know how this payment thing and the insurance thing, just the paperwork is amazing. Anyway, the barriers that we face to engaging competently in our care because we're unfamiliar with the practices and procedures of actually getting that care are huge, but many of them could be overcome if they were transparent to us. These aren't sexy topics, and they're not lively topics. They don't essentialize, you know, the peer-reviewed literature. They're not grand. But they really are, they're practical and they're necessary, and they correspond with big gaps in the abilities of so very many of us, even those of us who are well-educated and savvy and frequent users of healthcare, face these gaps in really understanding how to use the services of a specific hospital, a specific clinician, or a specific practice. So here's another thing that you need to remember as you put together your social media strategies. We only seek healthcare when our own efforts fail. So unless we're bleeding profusely or we have a symptom that really frightens us because it's gone on for a long time or it's severe, most of us really care for ourselves. You know, we seek help from our doctors and hospitals only after we've exhausted our friends and our families and the newspapers and the radio and online. It's like the court of last resort is healthcare. Our own clinician is rarely, and our local hospital is never, unless it's Mayo or Cleveland, never the source of good general information. This means that by the time we call for professional help, we are not looking for general answers. We're looking for very specific information about us, or our feverish baby, or our dizzy and breathless mom. And there's urgency to our need. We don't associate our clinicians with the provision of general health information. We can get general health information anywhere. Focus groups with a range of participants who varied by age and health status and race and geographic location repeatedly found that people say, I have an uneasy relationship with my doctor. She's pressed for time. My appointment feels rushed. My questions go unanswered. There are too many mistakes, too much miscommunication that can make things go wrong. You know, we seem to be most worried about getting timely access to our doctors. We fear angering our doctors if we challenge her authority or ask questions. We're worried about being offloaded onto team members or other people when we don't understand that person's expertise or their relationship to the person who we continue to accord the most authority, and that is our doctor. All of these concerns converge around interacting with our doctors, right? Primary care, specialists, doesn't matter. We seem to want to talk to our doctors, and we want the answers from our doctors. Now, the most unimaginative planners out there will say, don't worry, this is going to be solved by secure email, which is a part of phase 1 meaningful use, right? And so that's already been addressed. Well, you know what? I'd ask you social media innovators to worry. Sure, a nice patient portal with secure email with our primary care providers would be great. And we all know how soon that's going to happen for the majority of the population. And if that Yemen study that I mentioned before is any indicator, it's unlikely that it's going to be useful to everybody, even if they have access to it soon. So I would ask you to consider, is there any way to shortcut, supplement, or enrich the slow rollout of EHRs to find ways for us to get what we need from our busy and overworked clinicians to care for us and our families? Please, please, please help us with this. And finally, being sick is a serious business for us. Embedded in the enthusiasm about social media and patient portals and the proliferation of smartphones, there's this subtle assumption that being actively engaged with new technologies can somehow substitute for the pain and discomfort of illness. You have these bright, interactive online support groups with people like me and websites offering doctors answers to our questions and fun games to inspire adherence. And they're frequently presented at meetings like this as having the potential to turn the experience of illness into a series of small problems that are painlessly solved through the use of the technology. Remember, the context into which these new approaches enter, that is being sick enough to seek professional help, means that anxiety is running pretty high, that we may not be thinking clearly, we have painful symptoms, our lives are disrupted, and we feel out of control. Now, then there are those of us who live with the constant nagging of caring for our chronic conditions. And believe me, this is tedious, it's uncomfortable, and it's a lifelong job that already takes up far, far too much of our time. I once asked Amy Tendrich, who's the diabetes patient advocate who runs Diabetes Mind, that great big diabetes site, about the steady stream of new apps that she evaluates for users of her site. And she said flatly, "We will use tools and approaches that answer our questions and solve our problems. We will avoid tools that help us do what you think we should do, and we won't use tools that add to our work of caring for ourselves." It's great. It's great that a significant percent of American clinicians now have access to a rudimentary EHR so that we don't have to schlep our health records from doctor to doctor as long as they're in the same healthcare system. That's really important. And remote patient monitoring and assistive devices make caring for some people just so very much easier and give so many people much more access to their clinicians. Access to others in online communities really can be so enlightening about learning to live with your illness and reducing the incredible isolation that we feel when we're ill. These are all welcome, and they're especially welcome as more responsibilities are shifted to us and our families. But, my own experience with both chronic and acute illness leaves me with the impression that the value of social media is tactical, it's not transformative. at least for the sick person. The suffering remains. Health, and the lack of it, whether acute, like with cancer treatment, or chronic, as with asthma or diabetes, or a minor fluctuation, like that horrible cold you got that last year, that's when you felt like a freight train was coming right towards your body. All of this is a part of all of our lives. All of us want to be well, though. We want to feel energetic, and we want to feel happy. And we don't want to be distracted by pain or discomfort or sadness. But keeping ourselves alive and out of pain is a serious business. We want to spend as little time as we possibly can occupied with the drudgery of caring for ourselves. If we're going to use a new website or a device or a program or an app, we want it to be easy. We want it to save time, not take time. We don't want to have to learn a whole new technology and dashboard and stuff on the off chance that it might help us. And we don't want it to be fun. We want new digital technologies, including social media, to be efficient and useful. We want them to help us take care of ourselves and our loved ones so that we can live lives that are fun. Thanks. So now, let's chat. We have some time. Questions? Comments? Disagreements? Yes, ma'am.
I wanted to comment on what you were saying. I at the moment I've worked for the last year and a half as a patient advocate in hospital setting. It's a career switch for me, but what you're saying is true over and over again. The patients that I see in hospital are asking for a few key things. Information from a person, preferably their doctor or nurse, eye contact when people come to talk to them, quiet, and really human needs. And the older population that you address, that's true. Many of them are alone, or their children come, on occasion to deal with it, but they're left alone to deal with their health problems. And also, there's 100 million people living at poverty level or below in this country. And that whole population, young or old, at least in my experience, at the hospital, don't rely on social media to address, a lot of their needs in crisis. And then the last comment I want to make is just the number one call that I get is people losing their smartphones in the hospital. So if you lose that, you've lost everything. And I'm sure everyone knows that hospitals are not responsible for replacing that. It can get lost in the bed linen, or, get stolen, or there's any number of ways to lose it. So I think that while social media is really helpful, the human connection can't be replaced. I hope it will kind of alleviate some of the stressors so that people can really do their job. Healers can heal, and patients can be healed, not just cured.
Thanks. That's an excellent comment. And I think, in some ways, when I said at the beginning that I think that there are tremendous opportunities, but that they really are going to require careful and strategic thinking to take advantage of. And when you're working for a hospital, hospitals have many different aims in addition to patients' needs. Their self-promotion and their reputation management and all of those things. What I'm talking about here, from my perspective, from the patient's perspective, is only what we need, not what hospitals need. What we need in order to get good care and make the most of it. And we need really tactical information, and we need to get, to clear our way towards being able to talk to the authority that we need. So, making it easier for us to find the information that we need in order to figure out how to get to our doctor or how to make use of healthcare services, and then to make sure that we only seek care when we really need to seek care. That there's not something that we can do for ourselves that would allow us to stay home and not go to the emergency room. Yes, sir.
Hi, Bob Madison at Engage 360.
Yes, hi.
Slightly not off topic, but slightly more conceptual. If you could go through time back to the beginning of your cancer odyssey and tell your doctor just one thing, what would you tell him?
Don't talk to my mother. Talk to me. I was a difficult patient because I acted out so badly because I was 20. I was diagnosed on my 20th birthday with Hodgkin's, and I was in life support, and I was so blitzed out. You cannot imagine. But I was just I was just so angry that they would talk over my head. They wouldn't talk to me. Nobody talked to me. So I think, but that's a kid thing, But I just came back from my dad is in the hospital, and I watched the doctor talk to my mom, because my dad is he's more cognitively intact than my mom is. But the person in the bed, it's like you get in the bed, it's like you're not there anymore in any kind of coherent sense. So that's what I would say. But I think that's not what those stories were not what you were looking for. You were looking for a more
it's
uplifting.
Just that, I think one of the most resonant things that I've heard in the course of the conference was that there is no after suffering. So since we tell our clients, one of the first things we do is always put a human face on whatever it is we do. So I was just wondering if you could go back in time and talk to your doctors and say, guys, this is what we really need. And you actually answered my question.
Okay. Thanks. Well, I think that's right. There has to be a human face. There's plenty of stuff out there that has no human face, and you don't need to do that because other people are already doing it. WebMD, perfect. No human face anywhere in sight. So the things that you can work on it, and I think that the virtue of social media is that it can have warmth. It can have that sense of connection, and I think it will be the most gifted among you who figure out how to use that to help us connect in a way that is satisfying to us and that helps us to do the work that we need to do, which is to use the best that science has to offer, use the best that our own resources can afford to care for ourselves.
Joan Liebman-Smith, medical writer. I really appreciated the little graph you had of what a page would look like, easily navigatable, if that's a word. Because I think when you're a patient or you're the spouse or parent of a patient, you want to get to the information as easily as possible. And so many websites now are like magazines. They're all over the place. They're exciting, they're visual, they're fun, and that's not what we want. And I think that any hospital or healthcare organization really has to go to the old-fashioned, nitty-gritty, easily readable print. And also I made a comment yesterday about how everyone's into video and podcasts. A lot of us don't have the time to sit and watch that. We just want the information available. And I'm glad you're asking patients and getting answers and
Thanks.
Disseminating that.
Oh, thanks. Thank you. Well, yeah, this fun thing is insidious, and I think it's because many of the people who are developing these new apps and these new sites and stuff for people with chronic conditions don't know what it's like to have one, but they imagine and they think, God, that just sounds so boring, and you know what it is? It's really boring. It's really boring. It's so tedious, but that doesn't mean that the tools that we use to solve it are going to need to be the things that are not boring. They just need to be really useful so that we can have other things that are not boring in our lives that are not taking care of ourselves. And we really, this is, you hear it again and again. We don't want to spend time on this. We don't want to go onto a hospital website and listen to a podcast. I think that Mayo's doing just amazing things, but we can go to Mayo's site. We don't need to go to our local hospital site. When we go to our hospital, so I was taking care of my dad in Oregon. And I go to the hospital and go on the website, and it has all of these options for how I can send an email to somebody who's going to print it out and deliver it to my father. Now, that's very nice, but I would have liked to know when the cafeteria was open, and there was no sign of that. You know, it's like, God, come on, get with the program, kids. Anybody else? Yes?
Janelle Gracia, CardioSmart, American College of Cardiology. So we're in the process of making one of these websites that's trying to do it all, trying to provide really useful, boring tools like shared decision making, as well as providing things for people who are looking for how to lower their blood pressure, et cetera, that may or may not be a little gamified because you're serving such a broad audience, right? Heart disease is the #1 killer, so you're trying to serve so many different people. Do you have any ideas, though, for incentivizing, other than financially, the docs and the healthcare team to use these shared decision-making tools?
I wasn't here yesterday, so I didn't get to hear the comments on shared decision-making. But I understand that you did talk about shared decision-making yesterday. So here's, and my colleague told me a little bit about what you talked about. Here's the thing about shared decision-making. It's really good. Shared decision-making assumes that you have this moment of clarity where you are in a position to think clearly about what's going on with you. At the same time, you really need to make a decision. And deciding to take a statin is not highly loaded emotionally, right? It's not. And it probably is a really good idea for people to go through shared decision making for a statin. Although I do know that doctors don't like to do that. But it's hard for us to find the space, the cognitive and emotional space to actually go through that long process, what we feel might be burdensome and a long process, when we are making a decision that's more emotionally laden, right? Like deciding what kind of breast cancer treatment to have or whatever. I think shared decision-making tools are really important, but I think in some ways they're aspirational. I think shared decision-making in general is an aspirational model. What shared decision-making says to us, that kind of protocolized thing. You get the decision tool, you read the decision tool, and then you come and you talk about it with your doctor, right? That's the shared decision-making, that's how it's supposed to work, right? You guys know that, right? The doctor says, I would like you to look at this tool. The tool gives you the risks and benefits and the trade-offs. You go and read it, or you watch the video, or you look at the TV, the YouTube, and then you come back and you have this informed, shared discussion about it. I think this is great. I don't think most doctors are ever going to buy that. And I hear from patients say things like, "Well, if they don't know the answer, why are they asking me? I don't know anything," or "I don't want to know. I don't want to know this. I just want to." We have evidence that says that people say that they really want to share in all of their decisions, but when they actually get to the decision, they go, I don't think so. You just tell me what to do. And it differs depending on what condition and how much the risk is. But people are pretty ambivalent in the meantime about how much they want to participate in their decisions. But here's let me just say one more thing, and then I've been just like trying to wind up to get to you. I just want to say why I think this is aspirational and why I think shared decision making is so important. Shared decision making is really important because it says that this is legitimate for us to share information, that we can understand data, that we can understand evidence, that we can weigh trade-offs, and that's a legitimate part of a conversation that any patient can have with any physician. And that, if we decide, we don't want to do that, that's legitimate. But we should have the chance and the option to look at that information, to understand that information, and to make decisions based on a full understanding of risks and benefits. Right? So what shared decision making is kind of this rhetorical whack to get patients who get the rhetoric but often don't get the reality, and physicians to really say this should be a part of the conversation that happens between a physician and a patient and maybe the family. Your turn.
So two things. First of all, you've hit on the misuse of shared decision-making tools, which absolutely drives me crazy. The way they should be used in clinical practice is a conversation occurring between a physician and a patient. And they're used all the time in just the way you described. You're handed a tool, you're told to leave the office, look at the tool and come back and let me know what you think. But they're designed to facilitate a shared conversation by allowing the patient to identify their priorities and incorporate them in decision-making. The second thing is I work with medical residents all the time, and the most difficult thing to teach them is to recognize where someone is on that shared decision-making scale. Because it is a scale based on acuity, based on medical health literacy, and it can be very complex to decide where they need to fit in that particular environment. You've got to tailor your ability to engage them based on what they need at that moment in time. The power and value of an empowered patient is incredible. When you look at national guideline compliance, so if you go to the doctor and see that doctor, how often you get the right care, you know what we do the best at nationally is breast cancer. Because breast cancer patients are empowered, they're educated, they're enlightened, and they're a part of the process. So I really think from a provider standpoint, I want my patients to be a part of this process because they do better, and if they do better, I do better. But I think you've hit the two things that I think are critical. You've got to be able to read the situation effectively, so we've got to train physicians to know how to decide where someone is at, and they've got to be using the tools appropriately. You just don't hand someone a video or DVD and say, I'll see you in 15 minutes. Let me see what we want to do.
Yeah, and I think people's willingness and ability to select in, hey, I'd like to use a decision support tool, is pretty low. I mean, most people don't know what a decision support tool is. And one of the things that all of us, every single one of us in this room really need to watch out for is when we walk out the door, we do not say decision support tool. We don't say social media. We don't say, well, we don't even say empowered patients, you know? We talk about people. We talk about people. We talk about people who are involved and participating in our care. We talk about going online and finding a website or finding or downloading an app onto our phone that will help us to do these things. We leave the jargon right here because believe me, it's just like we zone out when we hear that kind of talk. We just like, no, I'm gonna go walk my dog. Okay. Anybody else?
Hi.
Oh,
Hi, I'm Wen Dombrowski. I want to thank you for your talk. A lot of points that you said I think I definitely agree with in terms of it is very hard for patients to navigate the system and to be responsible for an overwhelming amount of information. And I guess the point I want to make is not so much a question, but I just wanted to share my reflection on the talk, which is I think that there's a lot of variety amongst patients. I'm a physician myself, and I see that patients really vary on the spectrum. And I think we have to be cautious when we're representing the patient movement by saying we as patients want X or we as patients want Y, because every patient is different. Some patients want the apps and they want the decision support tools and they want the PHRs, and some patients don't want any of that. They don't want the paper. They don't even want the paper. They don't even want like the printout or anything. So I guess I just wanted to reiterate, like both as a physician and having been a patient myself, that different people want different things, and it can change. And just because today they were diagnosed and they don't want to hear it, maybe in a month from now or a year from now they want to do extensive internet research. And I think it's important for health professionals as well as the people who are doing social media or doing patient advocacy or navigation or running hospitals that they recognize that while there's variety amongst different patients, also within an individual, they go through different stages of grief, different stages of processing information, and to really tailor your solutions to those variations.
Excellent point. Thank you very much. Excellent.
Hi. My name is Maya. I work for the National Association of Public Hospitals in DC, yes. And we are doing a patient engagement session with a bunch of hospital CEOs and C-suite level folks, and I was wondering if you have a different angle or a specific message that you would use in talking about this with those types of administrators in that level of the hospital.
If let's see, if I were giving this talk to them, yeah, the talk that I give to hospitals is different from this talk. This was very different. Yeah. Anybody else? Time for the next talk. ended perfectly on time.